The trigeminal autonomic cephalalgias, or TACs, are not migraine. They are a completely different group of primary headaches, and the most famous of which is cluster headache. It's also the most common. The others you may or may not have heard of. One is called paroxysmal hemicrania. One is called short-lasting unilateral neuralgia form headache attacks, or SUNHA. And one is called Hemicrania continua, or HC. And I want to take you through all four and explain a little bit about each one. They're quite different, and they're not migraine, and they're more rare than migraine. But let's start with cluster, because cluster is the most common. Cluster is primarily a disease of men, at least 3-to-1 male, although there are women that have cluster. And we have an international classification of headache disorders that lists these TACs, these trigeminal autonomic cephalalgias. And I'm going to keep coming back to how the ICHD defines these four headaches and how to diagnose them and what doctors or providers are supposed to do in asking the questions. For cluster, a person needs to have had at least 5 attacks. And cluster is a very severe attack, very severe, usually around one eye or temple. It's strictly on one side, and it always stays on that side during a period of cluster. And each attack is 15 minutes to 3 hours, shorter than migraine. Migraine's 4 hours at least. The headache has to be accompanied by at least one of a variety of unusual symptoms or signs. A red eye, and this is always on the same side as the cluster, tearing, nasal congestion, runny nose, eyelid swelling, forehead or facial sweating, a small pupil, which most people wouldn't recognize, but a droopy eyelid, which you can see in the picture here, or a sense of restlessness or agitation. I saw a man today in my clinic who did not have any of the first 5, but he was intensely restless. He had very severe attacks. Each attack lasted 1 hour and occurred 1 to 2 times per day, generally at the same time of day. That's usual for cluster, once or twice a day, but they can go up to 8 a day. And there are 2 types of cluster. There's cluster in which people have daily attacks, and then they go for a period of no attacks for at least 3 months in a year. That's episodic cluster. There's chronic cluster, in which they have attacks every day and they never get 3 months off in a year. Those are the 2 types of cluster. But remember, these are short attacks around the eye with all of these other features and agitation. Person would not go to a dark, quiet room, as with migraine. Mostly men. Doesn't look like migraine. Now, more than 30% of people with one of these 4 attacks do get pain in between the attacks. It's usually described, except in Hemicrania continua, it's described as a ghost pain on the side of the cluster attacks. But cluster, to make it a little more complicated, is more common in people who have a personal or a family history of migraine. Still, it's 4-to-1 male. The attacks occur at the same time of day or night, and often at the same time of year, and the attacks are almost always triggered by alcohol. So those are a few aspects of cluster that make it unusual. And we can tell the attacks apart from migraine by what's called functional imaging. It's a special kind of imaging to see where the brain is misbehaving. And in cluster, that is in an area called the hypothalamus, and it's on the same side as the cluster attack. You can see it here in the orange in the middle of the screen in a functional MRI study of cluster patients that is 20 years old, and that showed us where the clusters come from. Each of these have different functional imaging. That's how we know they're truly different. The second TAC is called paroxysmal hemicrania, or PH, and it looks exactly like cluster, except it's shorter. The attack generally lasts only 2 to 30 minutes. Now, it can overlap with cluster because a cluster attack can be as short as 15 minutes. But the average duration of a PH attack is 13 minutes, a lot shorter than cluster. But you can see the 6 ways that you diagnose it are all the same as cluster, on the same side as the attacks: red eye, tearing, nasal congestion, runny nose, eyelid swelling, facial sweating, droopy eyelid, agitation. But here's a difference. Cluster usually occurs once or twice a day. PH attacks occur more than 5 times a day. And again, the rule of 13, the attacks last 13 minutes, and they average 13 attacks per day. And another big difference from cluster is that there is a key in the lock treatment for PH, and that is the medicine indomethacin. And when the indomethacin gets to the correct dose, the attacks stop. 100% elimination, a key in the lock. That doesn't happen with cluster. It doesn't happen with many headaches. But the attacks are shorter. They occur in women and men about the same, but there are more frequent attacks per day, more than 5 a day. And like cluster, PH can have 3 months off in a year or more. That's episodic PH, or it can be chronic and never get a day off. That would be chronic paroxysmal hemicrania. So different than cluster, but very similar. You can see how these attacks are in the same group, but the imaging is different. PH is associated with hypothalamus activation, as is cluster, but in PH, the activation's on the other side of the brain. And then there's an additional area that gets activated in PH that is also activated in migraine, and that's in the upper brain stem. But in migraine, it's on the same side, and PH is on the other side. So each of these, what are called primary headache disorders, come from different areas of the brain, depending on which side and how they mix and match. The third TAC is Hemicrania continua, HC. And this is a continuous one-sided headache, usually moderate to severe, present for more than 3 months, and it periodically worsens, and very frequently worsens, to moderate to severe pain. And people with PH will say, well, my daily headache, which never stops, is 6/10, but every day or two, it goes up to 9/10. And look, the HC has the same features as cluster and PH. On the same side as the headache: red eye, tearing, nasal congestion, runny nose, eyelid swelling, facial sweating, droopy eye, agitation. Like PH, HC responds completely to indomethacin when you get the indomethacin to the correct dose. Indomethacin is like a super aspirin, a super Advil, a super ibuprofen, but it requires a prescription. It takes getting used to, and you have to work people up to the correct dose, and then bang, the headache stops. This is often mistaken. HC is often mistaken for chronic migraine being on one side. But one difference is the agitation that's common in HC, which is not present in migraine. People want to go to a dark, quiet room with migraine. All of these unusual features that occur on the same side with HC, they can happen in migraine, but they're usually mild and they're usually two-sided. They don't look like this. And then indomethacin does not completely terminate chronic migraine. So there are multiple ways of telling HC apart from migraine. And then the imaging is different. And again, you have the hypothalamus activated in HC on the other side, and that's like PH. But the midbrain is activated on the same side, and that's like migraine. So a little bit of migraine, a little bit of paroxysmal hemicrania, all thrown together. You can see how these headaches overlap. The last and most rare of the TACs is called SUNHA. which it stands for short-lasting unilateral neuralgia form headaches, easy for me to say. And then there are two types of SUNHA, SUNCT, which is short-lasting unilateral neuralgia form headaches with conjunctival injection and tearing, and SUNHA, which are short-lasting unilateral neuralgia form headache attacks, or headache attacks with autonomic features. And these headaches are rare and short, and they are very severe. And again, they're around one eye or temple. They last anywhere from 1 to 600 seconds. They occur in stabs or series of stabs. And you can see they have the same features as all the other three, except no restlessness. So on the same side with the attack, red eye, tearing, nasal congestion, runny nose, eyelid swelling, facial sweating, droopy eye, comes on real fast, might tear, red eye, and then stops real fast. And if they get the red eye and the tearing, it's the form of SUNHA called SUNCT. If they get one or neither of those or the other features, it's called SUNHA. That may be a difference without a distinction. And people get these 5 to 6 attacks a minute, up to hundreds of attacks per day, and it doesn't respond to indomethacin. So it doesn't look like migraine, it doesn't look like cluster, it doesn't look like PH or HC. And these are the kinds of stabs. So when somebody gets SUNHA, and it's usually up in the eye and up forehead, they'll immediately move forward with a wince as they get the stab, eye turns red, starts to tear, nose may run, and they may get a group of stabs or what's called a sawtooth pattern. And that's not like the other TACs or like any other headache, frankly. And again, the imaging is different. So it was with SUNC, the imaging looks more like cluster. It's an activation on the same side as the hypothalamus. Now, TACs are rare, and everybody who presents with what appears to be a TAC needs to be worked up for other more common problems: tumors of the pituitary, tumors of the back of the brain, aneurysms, blood vessel causes. TACs are uncommon, and every person who presents with a TAC requires a state-of-the-art MRI without and with contrast, and consideration for an MRA, which is an MRI of the arteries. But we as providers need to be very careful not to just assume that this is a primary TAC. It can be due to something, pituitary tumors being the most common problem. There are a lot of treatments for cluster. The FDA approved the only medication that's approved for episodic cluster prevention, galcanezumab or Emgality. I prescribe that today. It's wonderful that we have a proven medication for cluster. The other treatments for cluster are not FDA approved, but are widely used: verapamil, anti-epilepsy drugs, lithium, and methylergonovine. There is a non-invasive neuromodulation device that's put on the neck called the non-invasive vagal nerve stimulator, or NVNS, or GammaCore. And the FDA's cleared that device for treatment of episodic cluster attacks and for prevention of chronic cluster when one adds it to medication. For the acute attacks of cluster, they come on fast, they're short, pills generally don't work, so we use FDA-approved sumatriptan injections, DHE, dihydroergotamine injections, or the GammaCore non-invasive vagal nerve stimulator, which is FDA cleared for that. But we also use oxygen, which has very good levels of evidence for terminating a cluster attack, and sumatriptan nasal spray and zolmitriptan nasal spray. The other TACs, remember that we tell that somebody has paroxysmal hemicrania or hemicrania continua by the response to indomethacin. That's how you tell. So Indocin, although it's not FDA approved, is the treatment for PH and HC. And for SUNHA, there are a variety of treatments that we try. Almost all of them are anti-epilepsy drugs: lamotrigine, gabapentin, carbamazepine, oxcarbazepine, and none of them is FDA approved because no company has ever bothered to do a study on SUNHA, but they work. They work for most SUNHA patients. So in summary, There are 4 TACs: cluster, paroxysmal hemicrania, hemicrania continua, and SUNHA. They're rare. Everybody who has something that looks like them needs a good workup with an MRI and an MRA. Galcanezumab is the only FDA-approved medication for any of the TACs, and it's for episodic cluster headache prevention. Sumatriptan DHE and the non-invasive vagal nerve stimulator are FDA approved or cleared for acute treatment of cluster. And paroxysmal hemicrania and hemicrania continua are the indomethacin responsive TACs. And so we treat those with indomethacin. And I thank you, and I'll turn it over to Shoshana for the questions and answers, and I'll stop the share right now.
Wonderful. Thank you so much for that, Dr. Tepper. I was like trying to take all that information in, and it's a lot of really amazing information. So just for anybody here who was wondering, we are recording this and it will be available on our YouTube channel either later today or certainly by the end of tomorrow. So please check out our YouTube channel, please subscribe to that, and you will be able to watch this amazing recording from Dr. Tepper. Again, I think that we have a lot of different people here, but largely 2 big groups. One group is going to be the people who know that they've been diagnosed with a TAC, and at least one TAC. And then there'll be people like myself, maybe, who have not been diagnosed, but are wondering, you know, do I actually just have chronic migraine or just episodic migraine? Is there something else going on? And so people in my kind of situation, we don't know a lot about TACs. And so this is a lot of really amazing information. So that's the perspective that I'm coming from, just a lot of curiosity and wondering. So first of all, let me start with this question. We see in our online groups a lot of questions where people will refer to cluster migraine, which is not an official diagnosis. So could you please, Dr. Tepper, explain why it is so important not to use that term and to make sure that we, you know, use the correct diagnosis term when we ask questions?
Right, there's no such thing as cluster migraine. So I'm glad we both are on the same page about that. Migraine itself can occur frequently, and it can wax and wane. And people with migraine will say, well, I get a number of migraines in a row, either days in a row or multiple attacks in a month. And then it kind of calms down, and for a month or 2, I may not have a lot of migraine, and then it'll pick back up again. And people refer to that as cluster migraine. It's not, it's migraine. Migraine waxes and wanes. People with migraine, as I mentioned, can have some of the symptoms that are part and parcel of all the attacks. They can have red eye. They can have tearing eye. They can have nasal stuffiness, runny nose, sinus symptoms. They can have sweating or a droopy eye. But usually, and this has been studied pretty extensively, most importantly by an Italian neurologist named Piero Barbanti, in hundreds of patients, most of those symptoms or signs in migraine are on both sides and are mild. Whereas in the TACs, they're on one side and they're dramatic. And anybody who has seen somebody with a cluster or with any of the other TACs will attest to the fact that those symptoms are very dramatic in the TACs. But what happens is somebody gets sinus symptoms, runny nose, stuffy nose, tearing with migraine, and they get diagnosed as cluster migraine. It's not cluster, it's migraine.
Right, exactly. And obviously, since there are different treatments, it's really important to know what you're referring to. So, so I definitely appreciate
treatments
that.
Are so different. There's some overlap. Right. Sumatriptan and DHE and non-invasive vagal nerve stimulation works for cluster and it works for migraine, but then there's a lot of stuff that's very different.
Right, absolutely.
Even the galcanezumab dose, the Emgality dose for cluster, right, is different than the dose for migraine. So again, important to distinguish.
Very important to distinguish. So that's really helpful. I saw that you mentioned in your talk that one of the biggest differences between hemicrania continua and migraine is the agitation and restlessness. And so we've already seen some comments here where people are saying, I wonder if I have hemicrania continua and not just migraine, or maybe you have both of them. And so it's good to know that that's a difference. I know when I get an attack, I've got to be out. There's no restlessness, no agitation. It's like, let me not even breathe because I don't want to move. So that's very interesting point of difference. Is there any other like key difference between them, or is that like the primary way that you would know?
No, the primary way you know is the indomethacin treatment.
Right.
So when, as I say, when you hit the right dose of indomethacin for HC, it stops.
Right.
As long as you stay on the indomethacin at that dose. For migraine, that does not happen. And for migraine, indomethacin can be helpful, just like any other anti-inflammatory can be helpful, but it is not a key in the lock. It doesn't stop the migraines cold. When people come back after they get on indomethacin for HC and they say, thank you. I mean, my life is completely changed. I want to get you a Christmas present. So it's really different. It's really different. And there are very few neurologic disorders where there is a key in the lock, and HC and PH are two.
Yeah, that's wonderful. What are they? I don't know if you're allowed to specify this. Obviously, I'm not asking for medical advice, but what is like the range of dosing that is used for indomethacin generally?
That's a really good question, completely legitimate question. It's very wide, unfortunately. I always refer my fellows to a paper by Cittadini and Goadsby that was published about a decade ago, maybe longer, on I think it was 32 or 39 patients with HC in a British migraine center where they really looked at the indomethacin dosing. What we do with indomethacin, we start with 25 milligrams 3 times a day with meals with stomach protection. And sometimes people will respond to very low doses. I remember a guy who he was a lawyer who had it for 5 years. Nobody had diagnosed it. I gave him the indomethacin prescription. He went to CVS. He filled it. He took a indomethacin at CVS. Before he got home, he was headache free.
Wow.
So it can be that exquisite. You can just dust some people with indomethacin. On the other hand, in that Cittadini and Goadsby case series, they had, I think it was a third of the patients or 10 out of the 40 patients required 300 milligrams or more. One required even higher. So I move the patients up and I say to every single patient, your pharmacist is going to think I'm crazy. I'm going to be pushing this dose higher and higher and higher. You get to 300 milligrams. If you're not really clear that it's gone, then it's not HC. It's probably chronic migraine. And if you are almost there, I will push it even a little bit above 300. I have a few patients that require more than that. So the range is anywhere from 25 milligrams twice a day to 300 milligrams. And I would say the average is 75 to 150. I'd say 150 is probably the average.
Okay, that's really interesting information. That made me think of another question, and that would be that we know that with people with migraine that often you don't absorb medications as well, so you require nasal sprays or injections rather than tablets. But does indomethacin come in anything other than the tablet, or you have to have that? And then if that is the case, do people with PH and HC have the same absorption issues as people with migraine?
I think the answer to the second question is we don't know. It's never been studied. Indomethacin is available as a suppository. And occasionally when I'm really desperate to try to get somebody used to the indomethacin, I will use the suppository initially and then move them over to the tablet. It's actually a capsule. And they do make an indomethacin liquid suspension, although generally people who aren't tolerating the capsule aren't going to tolerate the liquid initially either. In Europe, indomethacin is available as an injection. And the way they diagnose HC is somebody comes in and says, I got, you think it's HC, you give them a shot of indomethacin and they're better before they leave. And so it's called the Indo test, but we don't have that. So, and then the capsules, it's available as a 25 milligram short acting capsule, a 50 milligram short acting capsule, and a 75 milligram extended release capsule. And sometimes if somebody needs 75 or 150, they can just take one of those 75s once or twice a day rather than have to take it 3 times a day. It's tailored to the individual person.
Okay, that's really good to know. You also mentioned about stomach protection. So what would be some of the options that people can take to make sure that their stomach is protected?
It's been pretty carefully studied. There are two what are called proton pump inhibitors, or PPIs, that are specifically effective with indomethacin and are better than the others. And they are rabeprazole, which was Asifex, and pantoprazole, which used to be called Protonix. And most insurances won't cover the rabeprazole, even though I think it's a little better. It's generic, but they don't cover it. They cover pantoprazole. So usually I prescribe 20 milligrams of pantoprazole daily. People don't have side effects with it. And if the stomach is a big problem, I'll double that to 40 milligrams.
Interesting. Okay, that's really helpful. So I know that, you know, some people who are taking indomethacin or considering it, that will be really helpful information for them. I see a lot of questions coming in, so we're going to do our best to get through all of them as well. You mentioned imaging, and we've had some questions about that. So you talked about imaging during your talk. I know that for migraine, generally what we hear in our talks is that the recommendation is there is no imaging. So, but for TACs, what you're saying is that imaging is crucial.
But I want to make it very clear, there's a difference between the conventional MRI that you do to look for a tumor and what I showed you. What I showed you are special research functional MRIs that show you where the brain generators are for each of these disorders. You can't get those. Right. Clinically, you cannot get those. What you want to do is you want the imaging to make sure that there isn't another cause for the TAC.
Okay, that's really helpful. That's super good to know. So someone asked if you have to have an attack while you have the imaging. Obviously, the answer to that is no, because you're ruling out.
During an MRI, it's still going to be a normal MRI.
Right, no, that makes sense. Now with SUNHA, does the pain completely resolve between attacks? Or does it not linger at all? Does it have some lingering? Is it just like it's on and then it's off?
For most people, it's on and then it's off. But as I said at the beginning, all 4 TACs, as many as a third of people will have a little ghost pain in between. With Hemicrania continua, that's moderate to severe pain. But for the other 3, it's a ghost pain, just a slight lingering in between. But for most SUNHA patients, it's on, off. On, off.
Super interesting. Now, next question we have from someone who's watching right now is, can a person be in remission with cluster or presumably any of these TACs for 3 to 4 years? I mean, is it possible to be in remission for a really long time, or does that generally not happen?
Nope, we see it. Somebody came in today, the guy I saw this morning with cluster, I hadn't seen him for 3 years. His last cycle was 3 years ago. So when I saw him last time, galcanezumab was not available for cluster, and today it was, which makes it a lot different for him. Yeah, and I could say he had commercial insurance. I could send him to get the galcanezumab today, and he could get his first injections today. So yeah, it's quite changed in the last 3 years. But yes, there can be long periods of no attacks.
Okay, that's cool. We actually had a question backtracking a little bit to the imaging, just came in. It says, can we get the imaging only in research? Is that like the higher level imaging that you're talking about? That's at headache centers such as, you know, the Dartmouth Headache Center and other places like that. It's not generally available.
No, we don't have those. We don't have those. No, those are truly research imaging.
Okay.
Now, what every patient needs is a normal structural MRI without and with contrast, which in the setting of these 4 TACs will be normal.
Okay, wonderful.
You want to make sure there's not a tumor.
Got it. Okay, so just to make sure everybody got that what you're having is a regular structural MRI with and without contrast. So I just want to emphasize that. Yes.
Because the contrast is absorbed in a tumor and it can light up the tumor.
Got it.
But the kind of images I showed you are only done in research and in very rarefied research centers, very few of them.
Okay, that's a great information to have. Now, on a slightly different topic, and you and I were chatting about this right before we went live, is obviously there are a lot of things that can cause pain in your face and your head, you know, ranging from fibromyalgia all the way up to the TACs. So let's just going to narrow it down to trigeminal neuralgia and SUNHA so that we don't get too far off the track. how do we, is there a way of knowing like a trigeminal neuralgia generally manifests itself at the bottom of your face sooner at the top, or is it not as precise as that?
No, you got it. That's the main difference. Trigeminal neuralgia is generally below the eye and SUNHA above the eye, around the eye and above. And 95% of trigeminal neuralgia does not involve the eye and the forehead. 95%. 5% can, but you got to think about the possibility that it's SUNHA and not trigeminal neuralgia. Other differences are that SUNHA has all of this very dramatic change around the eyes and nose, the runny eye, the red eye, the runny nose, and the stabbing. And when somebody has one of these attacks in front of you, you can see it.
Right.
Trigeminal neuralgia, somebody will wince, but they almost never have those other features. Almost never. Occasionally tearing, but it's rare. It's really rare. And so it's usually possible to distinguish pretty quickly whether someone has trigeminal neuralgia or SUNHA. Having said that, there have been a number of articles and chapters. Raphael Benoliel is the expert on this, about the overlap. There can be either overlap or it can be impossible to tell. And sometimes the same medicines work in trigeminal neuralgia and SUNHA, so that doesn't help you. But it's location and it's those other features that are the distinguishing aspects.
Okay. And presumably, there are obviously people there who have both. And so then it's much more complex.
Yeah, very rare though.
Okay, that's good to know.
I mean, SUNHA is so rare. To get SUNHA plus trigeminal neuralgia, you're really getting rare.
You're pushing the envelope there.
You're really getting rare.
Yes.
Right? I don't know. I'm not sure I've ever seen it.
Okay, that's great to know. You did mention red eye, and we had some questions about the red eyes. People were saying, are you talking about swollen-like allergies, pink-like conjunctivitis, like pop vessels? I'm presuming you mean kind of swollen and going red like you have allergies, or different?
I mean the white eye, the right part of the eye turns red.
Interesting. Okay.
And in the case of SUNHA, it turns red. 5 seconds later, 10, 15 seconds later, it's white again.
Wow.
In the case of cluster, it's red for 3 hours. In the case of PH, it's red for 13 minutes. In the case of HC, it can come on and go away, but it's not, and it can be swollen. I mean,
right.
Swelling of the face is part of the description, although it's not very common. The swelling is not very common. Droopy eye is common, right. And a red eye is common. Tearing is the most common feature of the TACs, and it's pretty dramatic tearing. Right. So that's the answer to that.
Yeah, that's good. So does it go redder than pink eye? I mean, does it really just look like pink eye, or it's much more?
Looks really red.
Really red. Okay, so you're going to know it. So
really
that's
red.
The answer.
Not subtle.
Yeah, that's good. We had a question that just came in just now. We're kind of coming to the end. So if anyone has any questions, please post them now so that I can ask them. This person wanted to know, can TACs cause neck pain?
Yes, they can, but usually neck pain is with migraine. Okay. Neck pain and migraine go together like love and marriage. Neck pain is more common in migraine than being one-sided.
Right.
So close to 3/4 of people with migraine have neck pain. I've seen neck pain with cluster. It's very rare. I've seen it with HC. It's more common, but not a predominant feature. Generally, neck pain, it's migraine.
Okay. That's good to know. Well, not so good for people who have migraine. That's an interesting analogy you made, like this, like love and marriage. Not such a good thing, but we see that a lot in our groups. Obviously, people who have migraine, they complain about neck pain a lot. And so it's just one of those unfortunate aspects of migraine. This is going to be our final question for today, unless something pops up. Actually, we have another one that just popped up, but let me ask you this. If someone is indomethacin resistant and they have hemicrania continua, you mentioned some different options, but what would be like, if you had a patient who came in today and you knew they were indomethacin resistant, what would be the first place that you would start in terms of treatment for the acute attacks?
Well, there's no such thing as indomethacin resistance.
Okay.
Somebody might not tolerate indomethacin because the stomach problems are too great, or they might be contraindicated from indomethacin because they have had peptic ulcer disease or kidney disease and they're not allowed to take indomethacin, or they've had a gastric bypass and they're not allowed to take indomethacin. So, but there's no such thing as indomethacin resistance.
Okay.
So if you have somebody who you know has hemicrania continua, but who cannot take indomethacin, it depends why. If they had peptic ulcer disease, a gastrointestinal bleed, kidney disease, they can't take other anti-inflammatories. If they didn't tolerate the indomethacin, sometimes they will respond to another anti-inflammatory, celecoxib, piroxicam, diclofenac. So it depends on why they can't take it. But if they're absolutely forbidden from taking anti-inflammatories, that same device, the FDA cleared non-invasive vagal nerve stimulator, was cleared in the last year by the FDA for both paroxysmal hemicrania and hemicrania continua.
Wow.
That device, the NVNS device or the gammaCore, probably is the next step. The problem with it is most insurance won't cover it. If you're fortunate enough to be a veteran, the VA covers it.
Right.
And some headache centers have ways of getting a gammaCore device for people, but without coverage, it's between $500 and $600 a month.
Right. Yeah, it's very, very expensive for sure. And I know that they're trying to work on pricing, but the big issue is obviously trying to get insurance to cover it.
Now, there's one other treatment that I use off-label without good evidence yet, and that is to try galcanezumab, the Emgality that works in cluster, for some of the other TACs in people who can't take indomethacin.
Okay.
And sometimes it appears to work and people are very happy. So that is another alternative, but it's not FDA approved.
Okay, so it's just off-label. So that's good to know. This is literally going to be the final question from online right now, and then I'm going to close it with the last question. A couple of people are asking about, is tooth pain common with hemicrania continua? And is it common to notice blood pressure spikes a few hours before having a cluster attack?
I'll answer the second one first, because the group in Copenhagen studied all of the changes that occur before cluster, and blood pressure change was not common 2 hours before. Tooth pain is common in cluster. It's not common in hemicrania continua.
Right, because the symptoms are mainly on the top part of.
No, hemicrania continua is the whole side.
Oh, it goes down one side, right?
And it just, for some reason, some cluster patients do get pain into their teeth. It is something you hear in cluster. I don't think I've ever heard it in HC. Okay,
so that's good to know. And the final question is this: I know that there's going to be a lot of people who are watching now or who are going to watch it in the future who are saying, I wonder if I really do have something other than migraine, but I see a doctor who's not a headache specialist or who's not up on the latest options. You know, where do they go? What would be a first step for them to try to get some help and an accurate diagnosis?
Well, there are two organizations that certify headache specialists. One is the United Council of Neurologic Subspecialties, UCNS. UCNS offers a boards that doctors or providers have to pass in order to get accredited as a headache medicine specialist. And you can go to the UCNS website and put in UCNS diplomats headache medicine, and there's a list of those providers who have passed the boards for UCNS headache medicine. You can see if there's somebody in your area. If they pass the boards, they know how to tell these headaches. The other is that the National Headache Foundation offers an accreditation as well. And the difference there is that the UCNS does not accredit nurse practitioners or physician assistants, but the National Headache Foundation does. And so my nurse practitioners, for example, 2 of them are sitting for the exam in March. One of them's already certified, and you can check through the National Headache Foundation whether somebody is accredited in headache medicine. You really do want somebody who specializes in headache to separate out these TACs because they are rare and they overlap. Right,
absolutely. I'm just going to add a couple of other locations that people can go to add to that. One is that on our website, migrainemeanderings.com. If someone could put a link into the comments to that, we actually have a spreadsheet of every certified headache specialist from the National Headache Foundation and from the UCNS that is current. We're getting that put into a database form this year, but right now you can see it. You can look at it by state, you can look at address, by region, you know, anything you want. There's even some that people will mark if it's being recommended by a patient as well, but it's quite a significant list, not compared to the number of people in this country, but it's a current list. So hopefully that will be helpful to you as well. There is also NeuroHealth, which is a virtual headache clinic. So if people, they're not licensed in every state yet, but they're licensed in several and adding more. So that is a possibility for people, and they will do consultations with you as well. And of course, there's cluster buster support groups. So encourage you to connect with other people because they will talk to you about healthcare professionals near you who may be accessible as well. But as Dr. Tepper says, so important to have an accurate diagnosis. So, you know, we just reach out to anybody here who has a TAC or who thinks that they have one of these TACs, and just encourage you to get the help that you need. Thank you so much for being here today. Again, we encourage you to please take the survey that we posted in the comments. We just want to know what your diagnoses are or what you think your diagnoses may be. It is a confidential survey. It's not going to be, we're not going to share your information with anybody else. We just kind of want to know, you know, who's watching this. So again, thank you for being here. Dr. Tepper, a huge thank you to you. We really appreciate your time. As always, you know, you are so generous in coming and sharing your knowledge and your experience with people who live with headache disorders, and we really value you. So thank you so much for being with us today.
Thank you all.